Welcome back to the Progressive Podiatry Project. As always, I'm your host, Alicia Reeve. Now, I know that for most clinicians that deal with musculoskeletal injuries and also rehabilitation, getting our patients to engage in and adhere to our rehab programs is often one of the biggest obstacles that clinicians face. And that is what we're going to be discussing today. But there is going to be a little bit of a difference. So for those of you that follow me, especially on LinkedIn, you would have seen over the last couple of weeks/months, depending on when I'm actually going to release this podcast, is I've been doing some TLDR research roundups. So the whole purpose of the research roundups is to take current contemporary literature relating to lower extremity musculoskeletal pathologies and basically break it down nice and simply to help you inform your clinical practice. Now, I do have some big plans for a number of these research roundups. I am going to have potentially this being injected into our monthly CPD subscription, GFM, Gait, Footwear Movement. Now, there's already a truckload of content within that subscription. This is hopefully just going to enhance things a little bit more. Now, if you did want to find out about GFM, head to progressivepodiatryproject.com/GFM. It's a monthly CPD subscription, low cost, high quality, fantastic. We've got a few hundred clinicians in there already after a few months of being active. And yeah, so let's get into today's episode. Hi there, I'm Talisha Reeve, podiatrist, clinical educator, and injury rehabilitator, and this is the Progressive Podiatry Project. We're here to share knowledge, insights, and information to evolve your clinical practice and, most importantly, help you help your clients. Okay, so this study was focusing on developing a tool. So the attempt is aiming to assess the adherence to exercise for patients. So previous research has lacked some sort of specific tools for us to be able to measure this objectively and sort of monitor how engaged someone is with our rehabilitation or musculoskeletal management plan. Rehab might only comprise a small portion of this, but it's essentially engaging in and adhering to our management plan. So the attempt is designed to help us monitor patient adherence to exercise recommendations during treatment. And changes with the attempt score throughout the course of treatment we do use this along with patient-reported outcome measures or PROMs, but essentially using this, it can help interpret and give us information and us being able to interpret that information to gain an understanding of how engaged and how much someone is adhering to our rehabilitation programs. Now, because I want to keep this quite clinically focused, I will cover a little bit of the study characteristics, but it is open access, so you can download it from the BJSM site. We're going to go through the questions that are within this ATEMPT tool. Now, each of the questions, we get the patient to fill it out, and it's scored on a 5-point Likert scale. So the first question: I feel my individual needs were understood when the exercise therapist recommended my exercise. Now, this dials back to, are our exercise and rehabilitation programs individualized and responsive to patient needs? Now, lucky for you, if you haven't already downloaded this, a few years ago, I created the Movement Prescription Blueprint, which is essentially, it's a free resource that you can get from progressivepodiatryproject.com/blueprint. Now, it is literally designed to help step you through the exercise program formulation progress, starting from patient goals, identifying potential barriers, exploring their movement preferences, exploring their movement history, all of the elements that feed into someone adhering to and engaging with our rehab programs. It's there, it's free, it will step you through this. Now, when we're talking about the individual needs being understood, one, are we actually listening to the patient and formulating a program in a collaborative sense with them? So this is where there's that real big delineation between someone adhering to an exercise and rehab program or a management plan or complying with. So even though it seems like it's a slight nuance between words, it actually conveys a relatively larger meaning to this. So if someone's adhering to something, usually that is based on shared decision making. It's been more of a collaboration and a conversation. And when someone is complying or not complying, that is usually linked to that more authoritative, I always stumble on that word, authoritative patient practitioner relationship. Do this exercise because I said so. The end. It's really lacking oftentimes that little bridge of understanding that a patient needs to engage in their rehab, which that sort of comes in a few questions time. So basically, if we are to help a patient feel like their needs are being understood when an exercise is being recommended, this is where we take past experiences into account. Has this patient been given rehab exercises before? What was that experience like? Did they have a positive effect, negative effect? Were they given 50,000 exercises, they didn't do any? There may be a single parent that has 0.2 seconds of free time during the day, and then they've been given these 16 different exercises and been expected to do them. Is that really matching the rehab to what the patient can actually do? No, that means the patient is less likely to do this. So their needs being understood. So factoring in their preferences, movement history. When we talk about preferences, there are some people that they already go to the gym might be part of their identity, they're injured, and instead of doing 4,200 TheraBand exercises at home, is it possible to potentially integrate their rehab into the current gym activities that they're doing? We're just modifying what they're doing. So it's just for us to understand or help a patient feel like they're understood, we just need to ask questions, get to know them, get to know their preferences, and listen. Like theoretically, it's not that hard, but apparently it is, because we still have issues with people adhering. Okay, so moving on to the next question. I am doing enough exercise to produce a positive change in my musculoskeletal pain. This is where it comes into, it's sort of a multidimensional concept here. So essentially it is built on is the patient's exercises being delivered to the optimal dose? So are we underdosing the exercise? Are we overdosing the exercise? Overdosing, we tend to have negative consequences. The injury might flare. We may cause further injury. Underdosing, not much is happening. If we're hitting things in the optimal range, things should be progressing and not regressing because we've overdosed. And yeah, essentially we're hitting things in the optimal dose. Okay, so what may the patient see? So they may be getting a decrease in pain, or they may be seeing an increase in function, or a little bit of both. Now, it is important that and this is where it does become very important, that we're actually prescribing our exercises based on the current capacity of our patient. And this is where I am so anti-protocol. When you have someone that comes in and let's say it's Achilles tendinopathy, everyone starts with bilateral eccentric focused calf raises at 3 sets of 15 repetitions. If we've got someone who's quite high functioning, so say they're a runner and they're still knocking out 60 odd kilometers a week at I don't know, 5 minutes or 5 minute 30 pace, they have a relatively high level of function. It might just be when they kick into say 70 or 80 kilometers a week that it gets grumpy, or if they do interval sessions, so they're loading the Achilles tendon more with a faster pace of say 4 minutes 15 pace, something like that. If we give that person bilateral calf raises, is that going to be enough to stimulate positive tissue adaptations for them to increase their capacity? Potentially not. Now, a good way to visualize this is the Baxter paper from, I think, 2021, somewhere around there, 2020, 2021, 22. Now, that paper is exercises that incrementally load the Achilles tendon. That is a perfect way to visualize how the Achilles tendon might be underdosed with some of the exercises that we prescribe. Now, recently, I've been doing a couple of lectures that do incorporate that. So if you follow me on any of the social platforms, you probably would have seen my adaptation of that chart. And I know there's a few other clinicians out there, especially on Instagram. So Luke Nelson, Luke Nelson, chiropractor, he's one, Rich Willie at Montana Running Lab. So there's a few clinicians that have their adaptations of that chart. Anyway, so that's our potential overdose, not overdosing, underdosing, because their level of function is quite high. And then at the other end of the scale, we might say prescribe someone that bilateral calf raise, but they have a relatively low level of function. So for that patient, I'm doing enough exercise to produce a positive change in my musculoskeletal pain? The answer still may be no, but it may be no because we've overdosed them. So their capacity might be bilateral quarter range, 3 sets of 2 repetitions. That might be all they've got in the tank, even potentially less. So for us to improve the scores for this question, it is essentially just being able to marry our exercise prescription with the person's current capacity and be working towards their overarching treatment goal. So what activity are they looking to get back to? So this is where I refer to it quite often as the capacity gap. Capacity gap is where they want to be minus where they are. That's the gap. So if we have that understanding of, okay, they want to get back to running and currently they can do, I don't know, 8 repetitions of a single leg calf raise, and they can walk, but they can't walk up a hill because it stirs up the Achilles. All of that information feeds into us having an understanding of that capacity gap. So if we take the time to explore that, so identify patient goals, identify the functional capacity of what the injured tissues need to tolerate for the goal activities, perform our functional test to get an idea of where they're at present relative to that, and then we just fill in the gaps. So if we answer those questions, that's how we can improve this score. Okay, question 3. Am I doing my exercises as instructed? Now, how we can help with this is if we avoid doing what so many clinicians do that drives me insane, is when we're prescribing exercises as almost an afterthought. So say we've got someone in the clinic, plantar fasciopathy, Achilles tendinopathy, whatever the musculoskeletal problem is, and we've spent 30 minutes out of a 40-minute consultation doing soft tissue and ankle mobilizations, and then we've had our little chitty chat. They've taken 6 minutes to take off their shoes because, God, sometimes it does take that long. And then we get to the end of the consultation and we go, oh, shit, I have to progress the exercises. Quick, I'll scribble this down on a piece of paper. Here you go. See you later. Now, one of the problems is if we are not prescribing or taking the time during the prescribing process to really get the patient understanding the movement that we're doing. So there's a podcast I released relatively recently, or it will be released by the time this comes out, that it essentially steps you through the 4-step process I follow when I'm prescribing an exercise. And the whole aim of the game is to get a good score in relation to this. It wasn't based on this paper, but it's essentially, that's where if I'm taking the time to show a patient how to do their exercise, they're understanding how to perform it safely, they're understanding where they should be feeling it, the sort of correct technique without being completely over the top with correcting everything technique-wise, the better we're able to facilitate a patient's understanding of that during the consultation, the more likely they're going to do the exercises as we've instructed. So it's essentially, I will demonstrate the exercise, then I'll talk the patient through doing the exercise, going through any of the technique cues, correcting things if I need to, and then even the movement cues I give a patient, they sometimes will vary depending on what makes sense to that individual. So if I've given them some instructions of performing this exercise and then they're trying to do it and that movement cue is just not gelling with them, it's not making sense, I'll throw out a couple of different cues and, oh, maybe you should feel it here. Okay, maybe you move your foot here. And then sometimes I'll get the patient to tell me, like, okay, so for you to remember how to do the exercise that way, how would you remind yourself? Jot that down. That becomes their movement cue. So if we take the time for the patient to go through that process, then they'll really, you will increase the likelihood that they are doing the exercises as instructed. So again, I will, if you're watching on YouTube, I'll have the podcast episode or the YouTube episode listed on the video here. And for those of you who are listening on the podcast title that I'm referring to is 4 Steps to Effective Exercise Prescription. Okay, now we're moving on to question 4 within the ATEMPT tool. I understand how my exercises will help with my musculoskeletal pain. This is us essentially linking our therapeutic goals to the client goals. So this is our what to address their why. So what are we doing? What are we prescribing to help with their why. So their why is, I've got this pain that is stopping me from doing X activity. Our job is to try and help them get back to that activity. And we're going to use these therapeutic interventions to help you do that. So I'm giving you this exercise to help make the Achilles tendon stronger. So when you run and the Achilles tendon is lengthening under faster loads, it should be able to tolerate that without being aggravated. Similar things with the plantar fascia or ankle sprain. So you've sprained your ankle, you have some proprioceptive or balance deficits. I'm giving you these agility exercises to help the brain talk to the ankle a little bit better. So if we've got someone with, say, chronic ankle instability and we've got that delayed reaction time of the muscles, and that's part of the things that drive functional ankle instability, it's sort of a little bit of a neurological lag between the reaction time of the mechanoreceptors telling the brain where the ankle is at, and then the brain responding, going, I don't like where you're at. I want to change that via muscle activation. If it's delayed, then that's where we sprain our ankle again, right? So there are some exercises that we can do that focus on that neuromuscular coordination to try and help speed up that process again, so we can improve that reaction time. So it's essentially just taking the time to explain to our patient, you are being given this treatment modality in the context of this episode, your exercises, to address whatever the functional deficit or the goal is, essentially. So it's taking the time to explain that. And again, movement prescription blueprint will very much help there. Now, moving on to question 5. I understand the consequences of not doing my exercises. So we don't necessarily want to scare the living daylights out of our patients. It's more so having them understand, and this is, you will see this quite often, where I think there's another podcast episode that I talk about. There's definitely a blog that I've written on this where it's what we focus on, our patients focus on. And that example I used earlier, just where I was talking about, say we've got a 40-minute consultation, we've spent 30 minutes of that doing some soft tissue work, and then exercises are almost an afterthought. If we're kind of portraying that to the patient, like if math not good, 75% of our treatment is focused on manual therapies, and then there might be this sort of 10% that's focused on the rehab side of things, then that's kind of conveying that message to the patient, even if it's completely unintentional on our behalf. It is conveying that message to the patient that the manual therapy is kind of the really important thing. Oh, well, Talisha has the exercise as an afterthought, then it becomes an afterthought for the patient. So the consequences, so one thing is how we kind of frame what they're doing. So if exercise and rehab is going to be the bulk of what is going to help someone, then spending the time in your consultation kind of championing that, God, that word was hard, championing that treatment modality is what you need to do. This is what is going to help you achieve your goals. The manual therapy that we're doing is just opening that therapeutic window to calm down that pain that you're feeling so you can actually do your rehab. So part of it is how we're framing things for the patient, but then also the communication. So patient, we've done these functional capacity tests. Your capacity is down here. The activity that you want to do, you actually need your capacity to be up here. Now, there is no passive treatment under the sun that is going to bridge that capacity gap for you. It is the exposure to exercise that will get you there. If you want it bad enough, you're going to do the rehab. Now, if there's continued barriers as far as them not doing the rehab, that's when we sort of sit back and reflect on, have I addressed the patient preferences? Do they have enough time? Is there social or family or time constraints? What are the barriers that are stopping them being able to achieve that? So just making sure that we take the time, one, via framing what we're doing, which is not even something that we verbally communicate, as far as making a big song and dance about it. Like I said, that example of manual therapy versus the exercises. So there is that, but then there's also the explanation of, again, linking the therapeutic goal to the treatment goal. So this exercise will help you achieve this functional outcome. Now, lastly, I believe in the exercises that have been recommended to me. So can they see, do they understand how that exercise is going to build that functional capacity. Now, you do see this when you have people that it's the functional exercises. That's probably a perfect example. So true functional exercises are any exercise that is actually going to increase a person's functional capacity for their desired task. It is not, well, unless you are a circus performer, functional exercises are not doing squats on a Swiss ball. That's a circus performance act, really. But if that's what someone needs capacity for, then that exercise becomes functional. But in the grand scheme of what true functional exercises are, not so much. So a patient believing that the exercises are going to help them is one, we've been able to successfully bridge that sort of knowledge gap and join that dot between therapeutic goal and client goal. And then also just, have you given them enough understanding of, well, there's so many elements that feed into this, right? So if someone's got a relatively high degree of pain, do they have an understanding on the difference between pain and discomfort, utilizing the traffic light system? So the few podcast episodes and YouTube episodes I've got, which is load monitoring using the visual analog scale of pain, which is essentially how we can use the traffic light system, or the VASP, to, as that's improving, then we can increase our exercises. And it's also how patients can monitor their tissue responses in between appointments. So there's already some other resources that exist on the P3 platform, podcast, YouTube, and blogs on the website. They exist that cover that off. So it's them believing in this. So is this exercise going to help, or is it going to harm? If we give them that education piece, they understand difference between pain, discomfort. They have that understanding of that sort of self-dosage to keep their movement engagement a bit more consistent, giving them the tools for them to understand, one, how it's going to help them, and two, how it fits into their clinical presentation in a pain sense. So that's the ATEMPT tool, basically, and the 6 questions that are involved in that, and then hopefully a few insights that sort of will help you get better scores with the ATEMPT tool. Now, I just want to go into a little bit of detail as far as what the study was. So with this study, I think it was based in the UK. So they shot out about 2,000 questionnaires to patients, and they got a few hundred back. And most of the participants that gave the information regarding what metrics were probably the most meaningful and impactful, because originally the ATEMPT tool started off with a truckload. I think it was over maybe 50 questions across the 6 domains, and then they whittled it down to the ones that got the most response and tended to have the most meaning. So that's where it was whittled down to the 6. So most of the participants were female, about 60-ish%. Most were in the 66 to 75-year-old age range. Majority were white. Half of them were retired, and the knee was the most common site of pain. And then for experience, or the length of duration of symptoms, most of them on average was at least 2 years. So even just taking that demographic that made up the bulk of the participants for this study, depending on where you practice, for me, who I deal mostly with chronic musculoskeletal presentations and also running-related injuries, but for the pathologies of chronicity, that patient demographic really does reflect a large cohort of the type of patients I see. And they are also the ones that, or that patient demographic, well, that was described in the study for the bulk of the participants, that's often one of the cohorts that you find you might have the biggest hiccups to adherence, because we're not dealing with, so the hard part when we're dealing with active individuals is often getting them to move less, because moving too much has probably caused their problem. Whereas with other people down the other end of the spectrum, where we're more sedentary and there might be lower levels of health literacy, a few psychobehavioral barriers, especially, again, pathologies of chronicity, oftentimes it's a lot more coaching and that slow guidance towards behavior change that we need to do. So I feel that the ATEMPT tool is a fantastic resource for clinicians to, you don't have to maybe use it with every single person, but the biggest takeaway from this is when you're implementing an exercise program, are you ticking off all 6 of these categories? Are you making sure that your patient feels understood? Are you making sure that the dosage is in that sort of optimal range? Are you giving the patient adequate time and instruction to understand how to do the exercises safely and correctly? Have you bridged that education gap for them understanding why they're doing the exercises? So it's a fantastic way to reflect and improve our rehab adherence. So hopefully that's given you a little bit of a eye-opening understanding of, one, a tool that exists that you can use to, again, self-reflect and help you deliver more individualized, responsive rehab programs. Again, use the movement prescription blueprint because it will literally step you through that process. progressivepodiatryproject.com/blueprint. Now, where it becomes quite useful is if you have someone, maybe you're not getting them to fill out this Likert scale or the ATEMPT tool every single time that you see them. But initially it may be first appointment, you just considering all of those elements and making sure you're delivering a program that tackles that. And then maybe your first follow-up with the patient, running through those questions with them to kind of get that baseline, because everyone's more motivated at the start, right? So doing that baseline measure of engagement. And then it may be, if you see them in 2 weeks or 4 weeks, the next review, fill it out again. And then if there's consistency and that maintains, happy days. And then if things are starting to drop off, basically remeasure it. Now, if you find that something is dropping off, then there is something that is creeping into the equation that is affecting engagement. So it allows you to be quite responsive and proactive with addressing lower levels of adherence before you're sort of 6 months down the track and they've regressed completely. So hopefully that's given you a little bit of a rundown of a very handy tool that will inform your clinical practice. If you want to sign up to the monthly research roundup that I've got at the Progressive Podiatry Project, 100% free newsletter where it's essentially just sharing open access, quality, lower extremity, not all lower extremity, but musculoskeletal related journal papers. It comes out at the end of each month. progressivepodiatryproject.com/research roundup, free newsletter, sign up there, tons of resources on the P3 platform. That's why I've thrown out quite a few links at you today. It's been great. Look forward to the next one and I'll catch you then. Cheers.